بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, we will continue the lecture of imaging of arthropaths, and we have finished the first part. You remember that we started by the group of polyarthritis of unknown etiology, and we discussed the rheumatoid arthritis, the juvenile rheumatoid arthritis, as well as Stell's disease. Also, we have finished with ankylosing spondylitis. Now we will deal with psoriatic arthritis and Reiter syndrome. You know that psoriasis is a skin and skeletal disease, and it ranges about 7% of patients with psoriasis will have skeletal manifestations, and these skeletal manifestations will be commonly affecting the distal interphalangeal joints, as you can see here, and there is a well-known close relationship between the nail and skin changes of psoriasis and the involvement of the joints. The manifestations of psoriatic arthritis are almost similar to those of rheumatoid arthritis, except for some differences. We have destructive changes in the distal interphalangeal joint with erosive changes, as you can see, related to the articular surface. Then there is a peculiar manifestation of this type of erosion, and it produces a very characteristic deformity which is known as the pencil in cup deformity. And by time you get a resorption of the distal part of the phalanx and widening of the base of the terminal phalanx, giving a similar appearance to the pencil in cup. And this is the follow-up studies of a case of psoriatic arthritis in order to show the way how the pencil in cup deformity is developing. And you see here there is some erosive changes in the distal part of the middle phalanx, and you can notice the broadening of the base of the distal phalanx. Then by time you got erosion and resorption of most of the distal part of the middle phalanx, and the broadening of the base of the terminal phalanx, so that you got this very characteristic abnormality. And here you can see affection of the distal interphalangeal joints, and you got the classic pencil in cup deformity. In cases of psoriatic arthritis, there is no osteoporosis. In rheumatoid, you know, the osteoporosis is a well-known manifestation early in the disease and also late in the disease. There is no joint space narrowing because of this deformity, and also there is no ulnar deviation as seen in cases of rheumatoid arthritis. One of the well-known also manifestations of psoriatic arthritis is what is known as the sausage finger. There is diffuse soft tissue swelling of one of the fingers, associated with erosive changes characteristically in the distal interphalangeal joint, which is a common location for psoriasis. Then you got this appearance which is known as the sausage finger. In the spine, there is changes which manifest by what's known as syndesmophytes, which are the osteophytes arising from the mid portion of the vertebrae instead of the vertebral end plate. There is also atlantoaxial instability, which is also seen in cases of rheumatoid arthritis. But in cases of rheumatoid arthritis, you got more involvement of the facet joints, especially those in the cervical spine, as you remember. Then affection of the sacroiliac joints is also seen in cases of psoriatic arthritis. The affection is usually asymmetric compared to that of ankylosing spondylitis, which is usually symmetric. And you got narrowing of the joint space, irregularity of the articular surfaces, and bone sclerosis of the articular surfaces of the joints. And you know that this psoriatic sacroiliitis may proceed to complete bony ankylosis. Of course, you can easily discriminate between the changes of ankylosing spondylitis in the sacroiliac joints from the changes of psoriatic arthritis in the sacroiliac joints by the manifestations in the skin and nails in cases of psoriasis, and also the manifestations in the rest of the spine in cases of ankylosing spondylitis. You remember in cases of ankylosing spondylitis, early in the disease, you got bone marrow edema, which is better seen by MRI in the opposing surfaces of the sacroiliac joint bilaterally. And this bone marrow edema will appear bright in the T2 weighted images as well as in the STER images. You cannot see these changes in the plain X-ray, of course. And in the calcaneus, you got erosion with reactive bone sclerosis of the calcaneus. You got fluffy periosteal new bone formation and calcanean spur. And this calcanean spur, as well as the periosteal new bone formation, are also seen in cases of Reiter syndrome, but you still remember that the manifestations will depend in the differential diagnosis mainly on the clinical manifestations of the specific disease in other parts of the body. And this is what we call fluffy periosteal reaction, irregular inflammatory changes near the site of the calcanean spur. This enthesopathy, which is an inflammatory reaction commonly seen near the insertion of the tendo Achilles in the calcaneus. And you remember that this type of inflammation may also be seen in cases of rheumatoid arthritis due to inflammatory synovitis and Banner's formation, which will erode in the calcaneus as well as in the tendo Achilles, and this is considered one of the causes of spontaneous rupture of the Achilles tendon. And Reiter syndrome is a triad composed of urethritis, arthritis, and conjunctivitis. The etiology of the disease is unknown, and it usually affects young adult males. And this disease is sexually transmitted with asymmetrical distribution. The skin lesions and X-ray features may simulate psoriatic arthritis, but you go to the clinical triad, of course, in the urethritis and conjunctivitis. The course of the disease is usually self-limited and may subside within 6 weeks to 6 months. This disease is many times associated with avascular necrosis of the humeral head and the femoral head as well, and this may be attributed to the effect of the disease itself or the effect of the steroid therapy, which is the line of management of this particular disease. Here you can see an plain X-ray of the right shoulder. You can see that the humeral epiphysis is collapsed, fragmented, sclerotic, and there are some fissures within the femoral head, which are the common features of vascular necrosis in the head of the humerus, as well as anywhere in the human body. Then the common sites for affection by Reiter syndrome are the heels, the toes, and the sacroiliac joints. And this syndrome also have some peculiar manifestations which may be seen in cases of rheumatoid arthritis, such as periarticular soft tissue swelling and juxta-articular osteoporotic changes, joint space narrowing, and destruction. But some of the manifestations of Reiter also include perosteal new bone formation, which is a common feature, as you can see here along the metacarpals. Tendon calcification or ossification can be seen, like those of in cases of, for example, the supraspinatus calcific tendonitis. And this is an example. You can see this spot film for the region of the shoulder. This is the acromioclavicular joint, and this is the site, or what we call the third critical zone of the supraspinatus tendon, inserting into the greater tuberosity, showing an oval-shaped area of calcification, which may be appreciated here. You know that MRI is less sensitive for the detection of calcium compared to the plain X-ray and the CT scan. In the spine, there are similar manifestations to those of psoriasis concerning the development of syndesmophytes, which are osteophytes arising from the midvertebral body, crossing the disc space, and may fuse with syndesmophytes from the above vertebral level. Also, the changes in the sacroiliac joints are similar to those of psoriasis, except that psoriasis may proceed to bony ankylosis, but in cases of Reiter syndrome, the lesions do not usually proceed to bony ankylosis. And you remember, the affection is asymmetric, and it may be bilateral or unilateral. The earliest sign of sacroiliitis is the development of bone marrow edema on both sides of the articular surface, as you can see here in the right sacroiliac joint. Then these are the lesions which may be associated with affection of the sacroiliac joints. Number one, ankylosing spondylitis, psoriatic arthritis, as we have mentioned, arthritis with inflammatory bowel disease, we mentioned it, Reiter syndrome, and reactive arthritis, or also osteoarthritic changes can be manifested in both sacroiliac joints. Then whenever you look at the sacroiliac joints, and you see that both joints are affected, whether symmetric or asymmetric, with narrowing of the joint space, subarticular bone sclerosis, then you know that this is a chronic type of sacroiliitis. Then how can you predict the possible underlying pathology? Then you should go to the clinical data, and you should look to the patient, and you should also have some idea about the laboratory finding, so that you can reach the final diagnosis. Chronic sacroiliitis, and you see bone marrow edema on both sides of the sacroiliac joints bilaterally. This is asymmetric affection of both sacroiliac joints. Then this is an indication of an inflammation, but if there is some active inflammatory process, and you got erosive changes of the articular surface together with the bone marrow edema. Then in the calcaneus, similar manifestations to psoriasis are seen, including bone erosion, spur formation, increased bone density, and the fluffy periosteal new bone formation. To differentiate psoriasis from Reiter syndrome, whenever you look at the ankle joint, and you should go to the clinical manifestation, the skin and nail changes in psoriasis, the urethritis and the conjunctivitis in cases of Reiter syndrome. Encephalopathy is also a manifestation of Reiter syndrome with affection of the insertion site of the tendon Achilles with inflammation of the retrocalcanean bursa, which may result finally in rupture of the Achilles tendon. Then we have finished with the first group of polyarthritis of unknown etiology. We came to the second group of arthropathies, which are the connective tissue disorders that are acquired. And here we want to discuss this systemic lupus erythematosus, the progressive systemic sclerosis or the scleroderma. There are other forms that will not be discussed in this topic. You know that systemic lupus erythematosus is a systemic disease which can affect the skin, affect the musculoskeletal system, affect the lungs, affect the vessels, and it has so many manifestations all over the body. But regarding the musculoskeletal system, the most common manifestation in the joints is what's known as malalignment, and you got flexion deformities, subluxation, dislocation of the joints, and very important that these subluxations are not associated with erosive changes. You know, in cases of rheumatoid arthritis, the deformities are preceded by joint erosion, juxtaarticular osteoporosis, and so on. But here you can see that the deformities are not associated with erosive bony changes. Then one of the common findings in the hand is this subluxation, which is the subluxation of the interphalangeal joint of the thumb. Then you should know also that these deformities are easily reversible. Whenever, even if you put your hand on the X-ray table, the deformities will come back to the normal alignment. Then there may be severe ulnar deviation, but remember, there is no bone erosions. Diffuse osteoporosis, of course, is one of the manifestations of the disease and also the sequelae of corticosteroid therapy. And here you can see multiple deformities like the swan neck and the boutonniere deformity. And whenever this patient puts his hand on the X-ray table, the deformities are realigned. Then also be sure that there is no evident bony erosive changes. And this name, which is Jacoda's arthropathy, is a disease which where the systemic lupus erythematosus is one of the diseases that can result in this type of arthropathy, which is nothing but multiple joint deformities without bony erosive changes. This may be seen in patients with Sjogren disease and sarcoid together with the systemic lupus erythematosus. The incidence of this disease is about 5 to 10%. Joint deformities are caused by ligament laxity, and the deformities, as in these diseases, are reversible by manual manipulation of the joints. And you can see an example of severe deformities of the hand in a case with systemic lupus erythematosus. You are able to see that there is no bony erosive changes to contribute to such severe deformities. Even look in the wrist, and you see the carpal bones are intact, and the radiocarpal joint is also preserved. You know that systemic lupus erythematosus is usually associated with bone infarctions and avascular necrosis at many sites in the body. And the infarctions are either secondary to the disease itself or the sequelae of the treatment with corticosteroid therapy. Bone infarctions have been discussed before. They are occur in the medullary cavity of long bones. They are similar to the Chinese figures, and they have low signal in the T1, high signal in the T2, may be surrounded by dark rim from outside, but this appearance is almost very classic for vascular necrosis or bone infarctions. This is an X-ray of the left hip showing typical appearance of a vascular necrosis of the femoral head with collapse, flattening, sclerosis, fissures, all the manifestations of a vascular necrosis. And you remember in the lecture of the hip joints, I have mentioned this, that the pathognomonic sign of a vascular necrosis in the femoral head is the presence of this black line separating the normal bone from, separating the dead bone from the normal bone. And if you see that the dead bone is of similar signal intensity to the normal bone, then this means that this is an early stage of a vascular necrosis. But if this dead bone has transformed into fluid signal, you are dealing with a more advanced disease. And if it is in the form of bone sclerosis, you got the severest type of the disease. Scleroderma is a disease which affects also the skin and affects the bones. The main manifestations in this disease are the resorption of the terminal phalanges and the soft tissue calcification. There may be erosive arthritis, but it's rare. Osteoporosis is also rare in this disease. Then if you look carefully here and you see that there is erosive or destruction and the erosion of the terminal phalanx together with soft tissue calcifications like those in the ligaments and also around the eroded phalanx. This is also a classic case of scleroderma. You see erosive changes or resorption of the terminal phalanges with extensive soft tissue calcification. And the mixed connective tissue disorder is an overlapping a disease with that has overlapping features of many of the previously mentioned arthropathies, including the scleroderma, systemic lupus erythematosus, polymyositis, and rheumatoid arthritis. From manifestations similar to rheumatoid are those including osteoporosis, periarticular soft tissue swelling, narrowing of the joint spaces, bone erosion, subluxation, and ulnar deviation. Features from scleroderma including resorption of the terminal tufts and soft tissue atrophy and contractions, as you can see here. Then the third group of arthropathies are those associated with inflammatory bowel disease. You know that ulcerative colitis, Crohn's disease, Weber disease, Sjogren, and sarcoid may be associated with skeletal manifestations which are most commonly seen in the sacroiliac joints. And the same manifestations seen and mentioned previously are present with these diseases, and you can know that this arthropathy is related to inflammatory bowel disease whenever you know that the patient had this particular type of inflammatory bowel disease. If a patient had ulcerative colitis and you see bilateral sacroiliac joint affection, and you know that this arthropathy is related to his ulcerative colitis, for example. And this is a patient with Crohn's disease. And you know from the lectures of gastrointestinal tract, one of the manifestations of Crohn's disease in the bowel is diffuse mural thickening and edema associated with stranding of the colic and intestinal fat planes. This is a case of proved Crohn's disease, and you look to the sacroiliac joints, you can see that the sacroiliac joints are almost totally ankylosed. Then you should relate these sacroiliitis to the gastrointestinal bowel disease. Now we came to the arthritis associated with biochemical and endocrinal abnormalities. We want to discuss here gout and the chondrocalcinosis or the pseudogout, alkaptonuria or ochronosis, hemophilia. And actually we will not discuss the remaining issues like hyperparathyroidism will be I hope that I have a lecture about the metabolic and endocrinal bone diseases so that I can include the hyperpara, the acromegaly, thyroid acropathy, and the remaining issues. Then gout is a metabolic bone disease related to overproduction of uric acid or failure of its renal failure of uric acid excretion by the kidney. In both conditions, there is hyperuricemia with crystal deposition, and this crystal deposition will be near to the joints, especially those of the foot and the hands. Then this is an important notice that coexistence of gout and rheumatoid arthritis in the same patient is considered extremely rare. This is the primary gout, and secondary gout may be, the condition of hyperuricemia may be associated with other diseases like leukemia, lymphoma, myeloma, myelofibrosis, psoriasis, polycythemia, anemia, and renal failure. Then what happens? There is a deposition of crystals near to the joint, and you got erosive changes that are very characteristic. They are sharp, punched out erosions, which do not affect usually the articular surface at the beginning of the disease. Then a latent period between the onset of symptoms and the appearance of bone erosions may be present. And if you look here, and you will see these manifestations, juxta-articular erosions. They are sharply marginated, clearly demarcated with a sclerotic rim, and they have an overhanging edge like the rat bites. If you look carefully here in the previous case, and you see what's meant by the overhanging edge, and then you got joint space narrowing is very late after destruction of the bone itself and the invasion of the joint. Little or no osteoporosis. This disease will not manifest by osteoporosis, and the crystal deposition will result in soft tissue swellings, which are known as the tophi, and these tophi are sometimes calcified. And here you can see that there is erosive changes, and these erosive changes are well demarcated. They are not at the joint line. They are somewhat away from the joint line, associated with soft tissue swelling, which later on may be calcified. One of the common sites for gout in the body is the metatarsophalangeal joint of the big toe. The crystal deposition will occur here near the joint line. There are sharp erosive changes, and later on the joint will be narrowed and is surrounded by the soft tissue swelling of the tophi. This is also a good example of tophi in the hand. You see this very sharp erosive bone erosion in the base of the phalanx, and other erosions proximal to the joint. The joint space is narrowed, and you see huge very articular soft tissue swelling, as you can see in this example also. Then gout may deposit crystals near the olecranium, and this is one of the known sites of crystal deposition in the upper limb. and also there may be calcification of the articular cartilage and the meniscus as well, which have a similar manifestation to the pseudogout. And the diagnosis of pseudogout is dependent on, mainly on the presence of cartilaginous calcification, but there is, as I will mention, there is no bone erosions or calcified tophi. Here is an example of gout in a classic location, the metatarsophalangeal joint of the big toe. You see the erosive changes which are away from the articular surface and associated with soft tissue swellings representing tophi. And this is an advanced case of gout affecting a classic location in the foot, which is the metatarsophalangeal joint with extensive soft tissue swelling due to tophi. Also, you can see other sites of bone involvement. You remember that tophi may be deposited in the periarticular area, and it takes some time to produce bone erosions. Then, based on this appearance, you may assume that easily that this is gout. You see minimal erosive changes, but you see the swelling, the soft tissue swelling of the tophi. And pseudogout is, or what is known as chondrocalcinosis, is the calcification of the articular cartilage or the fibrocartilage. Like, for example, the triangular fibrocartilage, the menisci in the knee, and so on. Chondrocalcinosis may be seen in what's known as pseudogout, hyperparathyroidism, osteoarthritis, ochronosis, gout, as I have mentioned, hemochromatosis, Wilson disease, acromegaly, and hypophosphatemia. Then the pseudogout syndrome entails the presence of calcium in the articular cartilage, in the hyaline cartilage, in the joint capsule, and the periarticular soft tissues. And if you look carefully in this plain X-ray, and you can see calcification of the meniscus as well as the articular cartilage. And this is also a good example of calcification of the articular cartilage covering the femoral condyle. This is the lateral X-ray of the knee. Also calcification of the menisci. And here is an example of pseudogout with calcification of the meniscus as well as calcification of the patellar articular cartilage. Also, a case of pseudogout, and you see calcification of the meniscus. And you remember in some cases of advanced osteoarthritis of the knee, you may got calcium in the menisci and also around the joint. Then we came to ochronosis, which means that there is a dark yellow color pigmentation of the skin. This is also a metabolic disease where yellow pigment is deposited in the cartilage and the connective tissues, leading to pigmentation, cartilage degeneration, and calcification. Then if this pigment has deposited in the articular disc, for example, which is made almost totally of the cartilage, then you got advanced degenerative changes of the spine, which are seen in a relatively younger age for the usual age-related osteo or degenerative diseases of the spine or the spondylosis. These changes are commonly seen after the age of 60 years, for example, but here you can see at the age of 30 years. These manifestations will include the severe appearance of the spondylodegenerative changes. You got narrowing of most of the intervertebral disc spaces. You got calcification of the intervertebral discs with air or vacuum phenomena within the disc space. And also you got osteophytes, bone sclerosis of the vertebral end plates. Then finally, we came to the hemophilia, which is one of the diseases of the blood that can affect the musculoskeletal system. We have hemophilia A and B, which are sex-linked recessive seen only in males, and the hemophilia C, which is equally seen in males and females. And this type of hemophilia do not produce bony changes. The bony changes are usually the result of hemorrhage at different sites in and periarticular. And then if you got hemorrhage in the periarticular soft tissues, it will result in increase in the density of the tissues surrounding the joint. Then you got the distension of the joint capsule if there is intra-articular hemorrhage. And you got disuse osteoporosis because of the limited motion of the affected joint. And chronic synovitis may lead to cartilage destruction and joint space narrowing. One of the major joints to be affected by hemophilia, many joints can be affected, of course, but we usually see these manifestations commonly in the knee joint. They are the result of these hemorrhages. Intercondylar hemorrhage will result in widening, this very classic appearance of hemophilia, widening of the intercondylar notch. Intraosseous hemorrhage will lead to lytic and cystic bony lesions. And subperiosteal hemorrhage is rare and may cause periosteal reaction. And epiphyseal hemorrhage may cause slipped epiphyses or premature fusion and deformity. Also, you remember that intraosseous hemorrhage may result in huge mass, which is known as the hemophilic pseudotumor. Because of these changes inside the joint and around the joint, you got secondary osteoarthritis with narrowing of the joint space, subarticular bone sclerosis, and subchondral pseudocystic changes. Also, you got chondrocalcinosis maybe in this disease. Hemophilic pseudotumor is the result of a large subperiosteal hematoma causing pressure erosion on the cortex of the underlying bone. There are two main common sites for hemophilic pseudotumor. These are the femur and the iliac bone. And if you look here and you see huge mass, which by pressure erodes the underlying bone, results in some periosteal reaction, and even you can see what's known as the Codman triangle, which is a manifestation of osteosarcoma. But the clue for the diagnosis of hemophilic pseudotumor is the presence of the manifestations of hemophilia in the adjacent knee joint. And you see a widening of the intercondylar notch, enlargement of the epiphyses, and the increased density of the periarticular soft tissue structures. If you use MRI, then you will see the deposition of a hemorrhage, which is now transformed into hemosiderin as black linear or masses of very dark signal in all pulse sequences secondary to hemosiderin deposition. And this may be sometimes mistaken for pigmented villonodular synovitis, but you remember that in cases of pigmented villonodular synovitis, these lesions will enhance after contrast injection. The pigmented villonodular synovitis is not associated with these episodes of hemorrhage, and the hemophilic patient is well known to the clinician to have hemophilia. And here you see the low signal appearance of the hemosiderin, which is located in the intercondylar notch as well as in the knee joint. هذا وبالله التوفيق والحمد لله رب العالمين والسلام عليكم ورحمة الله.